but what was the difficulties you are understanding? Which particular ones you had difficulties? Level number. Hello. Which?
Yes, sir.
Klinefelter syndrome වගේ වද? මාෆාන්ස් වගේ වද? ඒ වද ප්‍රශ්න තිබ්බේ? Which ones? Just to give the examples, so you can always go and read about them. That those are common conditions you might come across during your third and fourth year clinicals. And anyhow, those would have touched in the third, second MB lectures, I think, physiology lectures. So anyhow, if you have that difficulty, you can just point them out as you go on. It's all right, right? You can interrupt and tell that anything you want to comment. So it's up. It's doing for your benefit. So ultimately, if you don't learn, then it's a waste of time both for you and me. So if you have any difficulty understanding any at any point, you're free to interrupt and ask, right? Okay. So you just, it's all right. So this will be the second. So we'll do the second part of general examination today, right? So this will be second part of the general examination. Hope this connection would be stable today without interruptions. So any particular question from last time you want to ask? Any particular questions you want to shoot, clarify from what we had last time? Anyone? Right. Okay. Better you contribute and make it active session, then we can be more useful for you as well, right? Okay. Right. So that we will discuss about some part of the general examination. Today we will discuss the rest of the general examination, what you will come across during examination, right? So examination, we discuss about the different parts of examination, but then oral cavity examination, the oral cavity is an important part of general examination, right? Don't forget to examine the mouth, right? So there will be several things in the mouth: teeth, palate, tongue, pharynx, tonsil area, paratonsil area, right? Uvula. So all those things might give you important physical signs, right? So even in adults, if during a general examination, it is essential to examine the oral cavity. And sometimes in the exam, some candidates forget to examine the oral cavity, right? So it's don't miss it. It's an important part, and especially in a cardiovascular case, oral cavity is very important, because can you think of why? Why examining the oral cavity is very important in a cardiovascular patient?
To identify cyanosis.
Not cyanosis really. Cyanosis, you can, one thing, your tongue and the mucous membrane as a complication. So say somewhere a VSD or some other complex cyanotic heart disease. What complication they can have? They can get endocarditis, right? They can get endocarditis. That means infection in the endocardium, right? If they have structural abnormality in the heart, they can get a turbulent flow, and it can damage the endothelium, and that can cause infection in the endothelium. So a particular endocarditis. So if you get bad teeth, decayed tooth in the mouth, then that is a risk factor to develop endocarditis, right? So if there is decayed tooth, it might point towards the diagnosis. If patient has fever also, if patient has fever with underlying cardiac defect and having oral cavity, there are multiple decayed tooth, then that's might be pointing towards the diagnosis. Anyhow, if it is not the diagnosis, still looking for decayed teeth in the mouth and getting it corrected by filling them or removing them is part of the management. So anyhow, in a especially in cardiovascular case, examination of oral cavity is important. In a case of abdomen, again, important to examine the oral cavity because some infections and some malignancies might have abnormalities in the oral cavity, right? So you can examine under direct light. You flash a torch inside the mouth and look at different structures inside the mouth. If the tongue is large, especially it happens in children, the tongue is large, then you can't see the posterior part of the oral cavity. So in that case, you will use a tongue depressor, right? So with the right hand, with the left hand, you use a tongue depressor. Left hand, you use a tongue depressor, and with the right hand, you flash a torch and look at the mouth, right? Make another sob, right? This is not the examining the mouth, it's really looking at a sob, but taking a sob. But here, you use a tongue depressor, press the tongue down, and then flash a torch inside. You can see the posterior pharyngeal wall as well. Here, you generally in the ward they have metal tongue depressors which are reusable after sterilization. But you can use this wooden tongue depressors which can be discarded after use. Single-use tongue depressors can be used. So if you ask for them, they will be available in the ward. So you even can buy them. They are not very expensive. So you can have some in your pocket as well, right? So that's the way to examine the mouth, right? So what you can see in the mouth, one important thing is gingival hypertrophy. That means the gums become hypoplastic, right? As you can see there, right? Gums are very prominent and they might be inflamed, very red, and look unhygienic. And you might smell halitosis, bad breath as well. That indicates called gingivitis, right? So due to poor oral hygiene, maybe diabetic patient, you can see that gingival hypertrophy, right? With inflammation, it can cause gingival hypertrophy. In addition, some other conditions like leukemia, some type of acute myeloid leukemias can present as gingival hypertrophy, that gum hypertrophy. And some drugs like phenytoin can cause gum hypertrophy. And important HIV infections is supposed to cause gum hypertrophy. And some physiological conditions in pregnancy. Sorry?
Sir, excuse me. Sir, we
Yeah.
can't see the screen share. Sir, we can't see the presentation.
Sorry. I could have not have screen share. Sorry. Can you see?
Yes, sir. Now we can see.
Right, okay. So I just go through the previous one again.
Yes, sir.
So this is the oral cavity I described earlier, right? So you have the teeth, the hard palate, soft palate, uvula, tongue, gum margin, tonsils, paratonsil area, and the pharyngeal wall, pharyngeal wall, right? Child. But you use same technique for examining. If you can't see the mouth inside, because children have large tongue, it has a tongue depressor, right? So tongue depressor, use the tongue depressor with your left hand and push down the tongue, right? And then flash a torch and look at the posterior part of the mouth, right? That's what I told earlier, right? And this is gum hypertrophy we're talking about. The gum is inflamed and red in gingivitis, right? Due to poor oral hygiene. Gum can be hypertrophied without inflammation in conditions like leukemias, right? Some AMLs can cause gum hypertrophy, and phenytoin use can cause gum hypertrophy, and HIV infections can cause gum hypertrophy, right? So, gum hypertrophy can be an important physical sign. And one reason why phenytoin has gone out of fashion as an anti-epileptic is gum hypertrophy, especially in young children and girls. This is an anxiety thing. So that's one reason why we don't use phenytoin as a long-term anti-epileptic. We use only as a acute condition when we control the acute seizure during a acute episode of seizure, right? So that is gums, right? And then you have to look at the tongue, right? The tongue can be very useful physical site of physical science. This tongue, can you look, tell about this? What do you see in this tongue? Compared to normal tongue, what do you notice in this tongue? Color? It is more red, right? More like beef-like red color. And you can see it is surface again. You are taking the tongue in anatomy. Look, compare that what is seen in anatomy. What is the see here on the tongue?
Tongue has become smooth.
Very good. Tongue has become smooth, right? So tongue is smooth. So that means the papilla has been lost. Smooth, red, and more like inflamed-like. So called it glossitis, right? Inflammation of tongue is called glossitis. And this you see in which condition? In some iron deficiency anemia, right? Iron deficiency anemia, you can see this condition, red beefy tongue with deep papillation, right? So that can be useful physical sign in somebody with clinically anemia. I mean, this will point towards the iron deficiency. And this one, what do you notice on this tongue? On the surface of the tongue, what do you notice? What do you see here? What is there? On surface? What are these seen on top of the tongue?
Calcium accumulations.
No. What does you must say what you see? What you notice? Observe. The whitish area, whitish plaques, right? White plaques over the surface of the tongue. This is due to candida infection because, right? So this surface is covered with white creamy-like thing, and it is firmly attached to the underlying tongue. And if you try to scrape it off, right, it will be even raw area under the this white. Sometimes due to milk, deposits of milk can produce something like this, right? So because of the milk deposits on the tongue, it looks very white. So sometimes difficult to differentiate it from milk precipitate from candida. So if you just scrape it off, milk precipitate will easily scrape off. Candida will not scrape off easily. And if you remove it, you will find very red, red raw tongue underneath these white deposits. Right. So this is candida infection. Usually this occurs in patients with immunocompromised. Right. So normal to have candida infections on the tongue or in the oral cavity. It can be a feature of diabetes mellitus, poorly controlled diabetes mellitus, or it can be a feature of HIV even, right? HIV, even a patient with HIV, if you have candidiasis in the mouth, it indicates patient is going into stage of AIDS. Right? So it's a important physical sign. And you might see the same changes in the cheeks as well. White patches, right? And sometimes even in normal individuals, you can get this after antibiotic treatment. Right? Prolonged antibiotic treatment was given, especially broad spectrum antibiotics are given, which covers a lot of bacteria. Use a lot of and use antibiotic that covers a lot of bacteria. Then you risk having this oropharyngeal candidiasis. Was the reason why you get it after antibiotic treatment. Because the normal bacterial flora will get killed. The normal bacteria living in the mouth will get killed. So the pathological organisms can establish on the oral tissue, right? So commonly in children, we find this after antibiotic treatment, right? And this is this tongue. What do you notice here? this tongue is what does this look like? It looks like hair, isn't it? It's again, right? On side of the tongue, you can see this hair-like thing, right? So in white color, hair-like thing called hairy leukoplakia, right? This seen in the oral cavity and tongue. This hairy leukoplakia, especially on tongue, it's a pre-malignant condition, right? If you see this, in couple of years' time, this site end up with the carcinoma, right? So this is what we call hairy leukoplakia. It's a very important physical sign. If you miss it at this stage, next time when you see the patient might be having a leukemia, malignancy in the tongue, right? I mean, 5 evidence of early malignancy. So, very useful physical science. So, important examine the tongue during your general examination, right? So, the patient put the tongue out and examine the tongue under good light to see this physical sign. Right? Any questions? Are clear about it? Anyone want to know anything about it? Clear? So we'll move on then.
So we didn't hear the last one properly.
May I know what appearance of this tongue? Hello? What is current now? I know that. Can you hear?
Yes, sir.
And here the me screen sharing block කරලා.
Yes, sir.
හරිද? හරි. Okay, right. I think right. Okay, right. Thanks. Right. So, can somebody describe this tongue? What do you see? What is the obvious thing that seen change you see on this tongue? One only is this side, left side.
There is abnormal reddish color in the
Good.
tongue.
There's tongue is very red, right? Very red compared to normal tongue red. Anything else to notice?
It is swallowed.
Sorry?
Edematous.
A bit of edematous is it, but red edematous and more. What is noticed on the surface?
There is slight elevations.
Yeah, the papilla become a projecting more prominent papillae, right? Those are the papilla. These projections are actually papillae. So what does it look like? The part of this look like a what?
Strawberry.
Strawberry, yeah. It looks like strawberry, right? Because it is red like a strawberry, and then on surface like on a strawberry there is multiple elevations like small papillae, right? And this is called red strawberry tongue, and this is characteristically seen in scarlet fever, which is a bacterial infection caused by Streptococcus pyogenes. You will learn this in microbiology, right? Scarlet fever, and see this tongue in a disease called Kawasaki disease, right? Kawasaki disease is a disease of medium-sized blood vessels involved in including the coronary arteries, and which can lead to coronary artery aneurysm formation. It's a dangerous condition. So if you see this tongue, right, a strawberry tongue, two things, you have two conditions you have to think of is Kawasaki disease and scarlet fever, and both are serious conditions, even have mortality, right? So important physical sign not to miss, right? Okay. Clear? Any questions about that? So then the next one, what do you notice in the other tongue? Anybody, what do you notice there? Can somebody describe the tongue? What is the obvious feature there?
The tongue has some kind of abnormal patches.
And there are the depressed patches or elevated patches? Are they elevated patches or depressed patches?
Depressed patches.
Depressed patches, right? So this is what you call geographical tongue, right? Geographical tongue. Geographical means this looks like maps. සිතියම්මගේ පේන්නේ, and then they keep on changing shape. අද මෙහෙම තිබ්බට හෙට වෙන හැඩයක් ගන්න පුළුවන්. Right? So they keep on changing shape, and this is due to spontaneous depapillation of the surface of the tongue. සාංගයකට තියෙන papilla destroy වෙනවා, and then they regenerate as well, right? So you get it changing in shape, right? And this has no clinical significance. This is a normal phenomenon, which we don't know why it happens, right? But often parents get panic about this. Commonly seen in children, parents get panic about this, thinking what it is, but you don't have to do anything. Just reassurance is what's needed. So it's called geographical tongue, right? That is about the tongue. Clear? If you have any doubts, you can clarify straight away, right? So all right, don't wait till then.
Excuse me, sir.
Yeah.
Sir, we didn't hear about the previous that malignancy done because of that connection problem.
Right, sorry. Here, you heard about the candidiasis, isn't it?
Yes, sir.
Yeah, all right. This tongue this look like hair-like, like hair-like, so white color hair-like thing. You call it hairy leukoplakia, right? So there is a white streaky-like things, and this is a pre-malignant condition. So about a couple of years later, this will change into a malignancy on the tongue, right? So if you see this, you should act quickly, and you can see this in HIV patients as well, right? It's a feature of HIV patients also. If you see this, you have to do a biopsy and treat early. You can prevent the progression of the malignancy, right? That is called hairy leukoplakia. Okay. And then we'll move on to the oral cavity itself, right? So this might have to flash a torch at the back of the mouth, right? You might need a tongue depressor as well. Tongue is large. normally the back of the oral cavity look very pink, normal pink color, right? But in some children, you might or in adults even, you might find it is red, very red, and you notice blood vessels there, right? The dilated blood vessels. This is due to what? This is what we call pharyngitis, inflammation of the pharynx, right? So this is just a not a very significant thing, but this indicates inflammation of pharynx. But important thing is the tonsils are not enlarged, right? So this pharyngitis without tonsillitis, right? And anyhow, in adults, the tonsil, so you might not see tonsillitis in adults, right? Okay. And this one, can somebody describe what you see in this middle picture?
Tonsils are enlarged and there are pus accumulation on the tonsils.
Right. The tonsils are enlarged. Is it pus or something like that? It's membrane, isn't it? It's a membrane over the tonsil, right? It's whitish membrane over the tonsil, right? So enlarged tonsils and surrounding area are also inflamed, right? And there is like thing over the tonsil. And this commonly found this side. So infection is caused by virus. It causes tonsillitis with the membrane, white membrane over the pseudo membrane. Another I got just disconnected. Another, can you hear?
Yes, sir.
Right. Okay. Make what I have a bit of unstable connection today. Anyway, right. Okay. That is the tonsillitis with the membrane, right? And this one, the third, what do you see or there? Right? This is membrane-like thing. This is pustule. Pustule. And ඒගොල්ලෝ පහපකට තියෙනවා. Due to bacterial infection, usually Streptococcus pyogenes. Because pyogenes infection, we cause.
I'm sorry, sir, disturbing you. Sir, your sound is not clear.
Can you hear?
Yes, sir.
Another?
Yes, sir.
Sorry, I got to be I think better to stop the video. The video off කරන්න. Best of I think the video එකත් එක්ක මම හිතන්නේ මේ we lose sort of right. Okay, right. So this you heard that now this is called Streptococcus pyogenes bacteria. So that's the important thing. It brings you anything into mind? Streptococcus pyogenes infection in throat. What can it lead to?
Excuse me, sir. We can't see the screen.
Okay, sorry. The blocker aajega.
No, sir.
A screen share. Oh, today it's going to be a problem with the connection, right? So you can see now, no? Right. So this pustule, right? There'll be red base and yellow colored collection of pus over top of it, right? And again, precipitate. Sometimes this salivary precipitates can collect on the surface of the tonsil crypts. Tonsil, can you remember anatomy of tonsils? There's a crypts like that going down like that, and then this deposits in the saliva can get collected inside and form a white arc-like thing, right? And sometimes people mistake it as pustules. Those are not pustules; those are plaques, keratic plaques. Now, the way to differentiate the two is keratic plaques are white, and the tonsils are not inflamed. When there's pustules, tonsils are inflamed, and the pustules are yellowish in color. And at the base of the pustule, there will be red strip. Right? So this is caused by streptococcus infection. Does anything reminds you with that? Streptococcus sore throat lead into what? Afterwards. Any condition you can remember? Rheumatic fever, right? Rheumatic fever and acute glomerular nephritis as an immunological mechanism, not directly, but so it's an important infection, especially in children. Okay. Can you move on? Okay.
Excuse me, sir.
Yeah.
Sir, in tonsillitis, why there is a in second picture? Why there is a membrane-like thing?
That's exudate.
Okay.
That's exudate, thick exudate. Exudate forming over the tonsils, right? That exudate.
Okay, sir.
Right, sorry?
Okay, sir.
Inflammation causing exudate on the tonsil. That's what called the membrane, right? Pustule. So basically, pustule is well demarcated patch, right? Okay. Right. And then we move the ear. Right? When you examine the ear, mainly look at the ear, any abnormalities in the external ear, right? There can be small pit there. Small, skin tag. Ear might look abnormal. There may be abnormal formed ear, right? So observe those things. And if there is multiple abnormalities in the ear, external ear, that indicates which organ abnormal. Multiple ear abnormalities might indicate abnormality in some other organ. Yeah. The kidneys, right? So multiple ear abnormalities might indicate abnormality in same side kidneys, ipsilateral kidneys, right? So you have to actually check the kidneys with ultrasound scan, right? And other important thing about ears is you have to check for the low set ears, right? So when you draw a line, right, connecting both inner and outer canthus of the eye, canthus can right? Inner canthus, outer canthus, right? Both inner margin and outer margin. If you draw a line, in normal people, about 1/3 of the external ear is above that line, right? But if nothing is above that line, then you call it a low set ear, right? So here you can see in this child, in this line, the entire ear is below that line. So that indicates low set ear. If you can remember, the tongue, the ear actually forms somewhere down in the neck and then gradually migrates upwards to its final location, right? So any abnormality in the embryo that might arrest the ear normally ascend into the normal position. So it can be associated with the abnormalities as well, right? So this is a feature of some other syndromes, right? but you should know it's a low set, right? There are a lot of syndromes that are associated with low set ears, right? So how to look at it is, when you draw a line between inner and outer canthus, that in extend that line, at least part of the ear should be above that line. Okay? Another? Are you with me? Another?
Yes, sir.
Right, okay. Then we move on next slide.
Yes,
Right. So then after that, you have to look inside the ear, what you call horoscopic examination, right? In children, especially who has fever, you should examine the throat and the ears, right? Because those two are one of the common causes of fever in children: pharyngitis and middle ear infection. Can you remember middle ear cavity, right? So to look at the in the ear, we use the instrument called horoscope, and some books call it otoscope. Horoscope or otoscope, right? So use this instrument to visualize inside the ear, and it's important to hold this properly. You don't hold it like you hold the ophthalmoscope. You hold like a pen. You hold it like a pen, right? And keep it parallel to the face like that. So this is the correct positioning of the horoscope, right? You will have this in the board, right? You will have disposable or reusable nozzles to put inside the ear, right? So with the permission of the nursing staff, examine the ears, right? But you have to make sure that you hold the child's head properly. Otherwise, if child shakes his head, this nozzle going to traumatize the ear canal, right? One reason why we hold the horoscope like this is because if child struggles, or the patient struggles, the horoscope will move rather than traumatizing the ear, right? So this is why you should hold the horoscope, and when you look inside, this is how you will see it, right? So this is the appearance you see in a normal ear, right? This is what? This is the tympanic membrane, right? Eardrum in general term, eardrum, and this is the uncus that malleus, the short process malleus that attached to the tympanic membrane, right? And when you flash the light of the horoscope, there will be a cone of light like that. You pay the cone of light, right? This is very important. When you flash a torch horoscope inside, you see this cone. It reflects back like cone. The light reflects back like cone, and that is should be there in a normal ear, because the tympanic membrane is concave, bend inside, right? Because of that bend, this light cone of light is formed. When the infection inside the middle ear, right, tympanic membrane bulges out, and first thing to happen is the cone of light will disappear, right? Once this concavity of the tympanic membrane is lost, right, the cone of light disappears, and then you'll find blood vessels appearing on the tympanic membrane, and tympanic membrane are usually transparent. It becomes opaque, and you might see fluid inside the middle ear through the tympanic membrane. And ultimately, when the pressure inside the tympanic membrane increases, and the inferior part of the tympanic membrane will get punctured, and pus will come out. So those are changes you see when you examine the ear through the horoscope, right? So it's important examination technique to learn, right? How to hold the child, and how to hold the ophthalmos or horoscope, and what to see inside the ear. So the changes you see is, first thing that you see will be loss of cone of light, and then bulging of your tympanic membrane becoming opaque, and red blood vessels appearing on the tympanic membrane. You can see fluid inside the tympanic membrane, and then there will be a perforation, right? So those are things you will see in the middle ear examination, right? So do this is an important technique to learn when you start clinicals. So do it under supervision initially, and do it repeatedly. You know the technique, but we don't do. If you do this in the exam, right? definitely we don't accept you to do a short case of long case you can examine if you want, right? In a long case, the instruments are there. So if you have enough time, you can examine the middle ear. But in a child like a brain infection, like meningitis, encephalitis, coming with a febrile convulsion, then it's important to examine the middle ear in a long case, right? So if you at least attempt to examine the middle ear, if child is not cooperative, then that's a different story. But we should attempt to look at the middle ear in a child like febrile convulsion, suspected meningitis or encephalitis, right? Because infection from middle ear can spread to the brain, right? Is it okay? Any questions about that? Any questions about that examination? Shall we proceed then? Hello? Any questions? Okay?
No, sir. Okay, we can proceed.
And then on the face, we move on to the hands, right? In the hands, there are a lot of physical signs, right? You can have very long fingers, like this one. What do you call that? Arachnodactyly. Arachnodactyly in Mapulwa. Mapulwa adu digaine, right? So like that, the fingers are very tall, very long. You call that arachnodactyly. So homework, you go and find out the condition which give rise to arachnodactyly. One is Marfan syndrome, right? So this arachnodactyly, and then you can have short fingers like that, right? These long fingers, short fingers, you call it brachydactyly, right? Down syndrome is one of the causes for short fingers. Even Turner syndrome, you can have short fingers, right? And then in Down syndrome, you have what you call clinodactyly. Here, what happens is the fifth finger, small finger, is curved laterally, like that, not straight. It's curved this way. That is because this side of the small finger is shorter than the other side. So the lateral side of the small finger is shorter than the medial side. So the small finger is bent laterally, right? That is called clinodactyly, right? And that is characteristic feature of Down syndrome. Most of the Down syndrome babies have this feature. Short lateral side of the middle phalanx of small finger, and the entire small finger is being bent laterally, right? That's clinodactyly. And sometimes you can have fingers attached together. We call it syndactyly. And again, this can be associated with other syndromes, internal organ abnormalities as well, right? Some brain abnormalities as well, the syndactyly. And then you can have polydactyly, right? More than 5 fingers, right? And if you have it on side of the thumb, you call it preaxial. If you have it side of the small finger, you call it postaxial. Right? So you can have preaxial polydactyly or polydactyly or postaxial polydactyly, right? So some of these conditions sometimes can be associated with cardiac diseases, right? Congenital heart disease are associated with polydactyly, and this is autosomal dominantly inherited. So to have it, you might give it to your child, right? So these are the changes you see in fingers, right? In a child, child or adult, anybody, right? So adults usually they might have even corrected this abnormalities, right? Okay. Any questions about that? Shall we move on then? So then you can have hand deformities, congenital hand deformities. And what do you notice in this hand? What do you notice in this hand? What is the abnormality? The palm. Look at the palm, not the fingers. Sorry? Yeah. Again. Look at your own palm and look at this palm and see. Look at your own palm and look at this palm and see what the difference. Calling right? What did you say?
Yes, palm creases.
Yes, gamma creases, but what is wrong with palm creases? Make ජීවන රේඛාවනේ මම කියන්නේ ජීවන රේඛාව කියලා. හරිද? මේක මොකද්ද? සුද්ධ රේඛාවනේ. තව රේඛාවක් වෙනවා තියෙනවා සාමාන්‍ය පහළට. Right? So in this child only single transverse palm crease, right? Look at your palm, you will find two transverse palm creases. You know, in your hand there are two transverse palm creases. But in this child, you got only one transverse palm crease. This is already there. This is longitudinal crease. Right? So this is what we call simian crease. Simian crease. Single transverse palm crease. Why do you get these creases, palm creases? But also these creases. Just bend your palm and see. Where does the hand bend? Palm bend. Pull thumb across your palm. ඒ thumb එක හැරෙන තැන තමයි ධන රේඛාව තියෙන්නේ. thumb එක move වෙන තැන. මේ metacarpal heads වලින් නැවෙන තැන තමයි මේ රේඛාව තියෙන්නේ. Right? So these are sites where the hand actually bend during flexion. So these two transverse palm creases become one crease because the palm is very short. In Down syndrome, the palm is very short. So these two transverse palm creases join together and form one crease. That is what we call simian crease. Right? So it's a physical sign of Down syndrome. Single transverse palm crease. Right? Okay? Any questions about that? Single palm crease නෙමෙයි. This is a lot of students even see. Some doctors even get confused. Saying the Down syndrome will have single palm crease. Single palm crease නෙමෙයි. මේ රේඛාව කොහොමද තියෙනවා. මේ පහළට තියෙන රේඛාව කොහොමද තියෙනවා. මේක තමයි single වෙන්නේ. Single transverse palm crease, right? Don't get it wrong. And this one, what do you notice here? What is the abnormal notice here? Look at the fingers. What do you note? Two fingers?
Nails are abnormally developed.
Nails are hypoplastic. Good. Nails are hypoplastic. Good. Fingers? Just bend your fingers and see how do they bend and how this bend in this child, how it is bend. අපි මේක ගෙන් කරම ඇන්ගල් එක උඩ කරනවද නෑනේ? In this child, the index finger and small finger go on over the two middle fingers. Right? They're not overlapping fingers. Right? That's what we call adductor contractures. Adduction and adductor contractures causing it. Right? So this is seen in babies with Edwards syndrome and Patau syndrome. Edwards syndrome is trisomy 18. Patau syndrome is trisomy 13. This is trisomy 21, Edwards Down syndrome. That means you got an extra chromosome. So if you had three 21 chromosomes, you get Down syndrome. You get single transverse palm crease. If you get 18 chromosomes, you get Edwards syndrome. If you get 13 chromosomes, you get Patau syndrome. Right? So this abnormality in the hand is seen in both Edwards and Patau syndrome. But you don't see it much because these children, both Edwards syndrome and Patau syndrome, they don't survive after 1 year. The maximum is up to 1 year, right? So you might not see them in the old child, right? But an infant, you might see this abnormality. And that you might see the abnormality. And that may be a clue to the diagnosis of this chromosomal abnormality, right? We'll move on then. Any questions about that? Are you clear?
Yes.
Okay. Then hand deformities, right? So you can have different hand deformities that are acquired. That means you are not born with it, but you develop them later on, right? So typically you see these abnormalities in the condition called rheumatoid arthritis, not rheumatic. Rheumatic is rheumatic fever. This rheumatoid arthritis, there's autoimmune destruction of joints. That means the body is developing antibodies against its own tissue, right? So this is what you call cutaneous abnormality, deformity. Right here, the proximal interphalangeal joint is bent, and the distal interphalangeal joint is extended, and this is called swan neck deformity. Right? Right? Here, opposite of this one. Here, the distal interphalangeal joint is extended, right? Flex, sorry, flexed, and proximal interphalangeal joint is extended. The proximal is flexed, proximal is extended, distal is flexed, distal is extended. So cutaneous and cutaneous abnormality and swan neck abnormality are directly opposite of each other, but both are seen in rheumatoid arthritis. And again, this type of deformities, nodules and destruction of joints and functional inability due to this joint destruction, it can be painful as well. All these are seen in the condition called rheumatoid arthritis. So you examine the hand, see these abnormalities, then it points towards the diagnosis of rheumatoid arthritis. Right? That's why you look for these signs. So the general examination, find these signs might help you to diagnose a condition. Right? Clear? Move on then. Right. And then sometimes hand can show an underlying neurological abnormality. Right? Can somebody figure out what this is?
Erb's palsy.
Erb's palsy, good. Erb's palsy due to?
Upper trunk of the brachial plexus is there.
C5C6 is abnormality during birth trauma. Usually during birth trauma, a difficult delivery, the head is pulled with force, and that can cause stretching of the upper parts of brachial plexus, and that causes the arm to be adducted and forearm to be pronated, and wrist to be flexed and finger to be flexed, right? So you call this position what? Porter's tip hand. Porter tip එකක් ගන්නකොට පේන්නේ නැති අත පිටිපසවල ගන්නේ නේ. Okay, policeman tip hand කියලා කියනවා. If you angry a policeman, right? පතාවක් ගන්නකොට පේන්නේ නැති ගන්නවා වගේ, right? That's called Porter's tip hand or policeman tip hand, right? So this is called Erb's palsy. Nowadays they tend to call it upper brachial plexopathy. Brachial plexus එකනේ. ඒකේ upper brachial plexopathy කියලා කියනවා, right? There's other term used for this. So if you notice textbooks, you might find that term in terms of herbs, as I'm telling you, right? Herbs එනකොට ඒක පාවිච්චි කරන අවස්ථාවලුත් තියෙනවා. Upper brachial plexopathy කියලා. මේක මොනවද? This is what you call claw hand, right? And this is seen in lower brachial plexus injury, C8T1, right? You call the lower brachial plexopathy. Here what happens, the small muscles of the hand is supplied by C8T1, actually T1 segment of the brachial plexus. So the small muscles, the interossei, some lumbricals are paralyzed, and fingers be flexed because of the long extension, long flexures are there. The forearm muscles acting on fingers, the long extensions, long flexures. So they are functioning. The small muscle not functioning. You get this claw hand deformity. It's called Klumpy's paralysis or lower brachial plexopathy. Right. So these are two birth injuries. Actually, this upper cord, this is the lower cord. Right. What is this one?
Ulnar claw hands.
Very good. Ulnar claw hand. Because ulnar nerve supplies only this lateral, the two medial 1.5 part of the fingers, right? And because of the that you get this hyperextension at the proximal interphalangeal joint and flexion at the proximal interphalangeal joint. So, sorry, hyperextension at the metacarpophalangeal joint and flexion at the proximal interphalangeal joint. What are we doing? Okay. Right. So if the ulnar nerve is damaged somewhere on the elbow, common thing, or due to the leprosy, you can have this, right? And then we'll move on the bit of lightning is I will try to finish up before, right? So this is what I call clubbing, right? Important physical sign called clubbing. In a normal hand, and you can have this in hands, fingers and toes. In normal fingers, right? Look at your fingers in the distal phalanx, right? The skin is like that, and then there is the nail, right? And between the skin and the nail, there's an angle, right? Usually there's an angle of more than 165 degrees between the nail and the skin. Right? This is normal. Normal, there's an angle more than 180 degrees, right? And then what happens as clubbing develops, this angle is lost, right? So in a normal person, if you put your fingers together like that, there's a gap between two. So it. Right? Like that. Keep the fingers like that. There's a gap between the two nails, nail bits, bases, right? This is normal. But when you develop clubbing, this gap disappears, right? That's what called. So there are different degrees of clubbing, and this is early type, and this is advanced type, right? So the nail becomes very prominent and convex, right? And this is seen in a lot of conditions, right? Especially in condition of lung and heart. All cyanotic heart conditions have this, and all suppurative lung conditions. That means pus-forming lung conditions. Asthma won't cause this. Asthma doesn't cause clubbing, and pneumonia won't cause clubbing, right? Because those are not causing pus, right? So the abscess formation in the lung, bronchiectasis of the lung, AV malformation in the lung, right? And what do you call this? Atypical pneumonia sometimes can cause it, right? Interstitial pneumonia can cause clubbing. Cyanotic heart disease can cause clubbing. And in the GI system, some inflammatory bowel disease like Crohn's disease, ulcerative colitis can cause clubbing, right? So this is what you call clubbing. An important physical sign. Look in the hands and feet. Look at the nails, right? And you can see this in nails. Sometimes you can have only in the hand, so only in the toes, but not in the hands. Then you call it differential clubbing. You learn it when you get this condition. I don't want to bother too much about that. Right? You can have it only in the toes, but not in the hand. So if you're really interested, read about it. What is differential clubbing, right? So important thing is learn the physical sign, right? You keep the two fingers together, right? You find a gap there, but the gap get lost like that. And then progressively the nail become more prominent. The exact mechanism of this happening is not clear. It's thought that vascular proliferation underneath the nail bed is responsible for this. Increased proliferation of blood vessels there is the reason for this clubbing, right? And then nails, when you fill in the nails, you get this what you call koilonychia. That means nail become a spoon-like, right? And that whenever you see this in severe iron deficiency anemia, And then in some conditions, you get nails becoming very white nails, right? Leukonychia. And that happens in conditions that there is hypoalbuminemia, advanced renal disease, and advanced liver disease. You can have these white nails, right? So nails can give you a lot of clues to the diagnosis. And I just moved the, I'll use the slide. I have experienced a bit of lightning here, right? I might have to stop very soon. So I'll do these 2 slides and stop. And then about edema, right? So a patient may have generalized edema like nephrotic syndrome or liver failure might have generalized edema, but it may be localized to a particular part of the body only, right? And then it will be seen in the dependent parts due to cavity, only in dependent parts like feet in a person who is standing, over the sacrum in a person who is lying down, right? So way to demonstrate it is you press that area with the thumb for 5 seconds and then take your thumb out. If it form a dimple like that, after take the thumb out, it's called pitting edema, right? Pitting edema, that means indicate fluid in the tissues. So when you press, the fluid get dispersed and form a pit there, right? So depending on the depth of the pit, right, and the time it takes to become normal, you can grade clubbing, but that is not very important, not important to remember even, but just for the complete, I said that if you want, you can remember it, right? That is called pitting edema. It's an important physical sign, indicates liver pathology or heart pathology or renal pathology, right? I think we'll stop it here because it start to lightning. It's a bit tricky, right? We'll stop it here and we'll do the rest of it on the next day, right? Any questions, anybody? Hello? Any questions? Yeah, Ruvin, any questions?
So in clubbing, after the underlying cause is treated, is it reversible or irreversible?
Up to certain level, initially it's reversible, but after it's not reversible. After it has progressed, not reversible, right? Initially, early stage, it may be reversible. Okay.
Okay, sir. Thank you.
So, Helida, we'll stop it here because it's progressively lightening here, right? Helida? Helida, are you around? Okay, we'll stop it here, right? I'll contact Helida and arrange another day to finish this off, right? Okay?
Okay, sir.
Okay, we'll stop it because we check it is going to be, right?